Hello, everyone, and welcome to a very special episode today. This is our bonus episode of the Practice Perfect podcast. I am Jennifer McNamara, your host, and I have our lovely co host, Maya Turner, here joining us today.
Hello, everybody. Hope everybody had a great weekend.
Yeah, we're here on a Monday. So wake up, guys. It's Monday morning. We're here to
Wake up.
talk about wake up,
I'm
wake
singing.
up, wake up. Yeah,
Yeah.
I feel like singing the song Manic Monday by Cindy Lauper because it's like I remember as a kid going to school on the radio, like that song would play every Monday. It was
And
just
it was
like
so
clockwork.
important. And it was just like, why?
Yeah.
Why? Why? Yeah, totally get that. Yeah.
Yes. I know. For kids and for adults, nobody likes a Monday. So poor Monday, gets a bad rap. But we are here nonetheless to talk about none other than the MPFS proposed rule for
Yeah.
2026, the Medicare physician fee schedule, and a lot to unpack. And I know there's probably no way on earth we could even tackle everything that's in this proposed rule. But we want to tackle some important things. And I think one of the kind of cool things slash different things that came up was this two separate conversion factor situation. So, Maya, let's just kind of talk about this. What does that actually mean? What are they saying when they're offering two separate conversion factors and how we break that piece apart?
Well, it's very interesting and participating. Medicare is now really trying to break down and incentivize providers to be a part of the herding of value-based care. And the way that they're doing this is that they are qualifying providers who are participating are getting a higher dollar amount for reimbursement rather than the ones who are not. And it's not that huge of a difference per se, but when you kind of look at the role that ACOs and Medicare replacements are doing, they really are changing the way that they're paying them by the way that they're qualified and non-qualified. So they've changed this, and it's in several things. Now, again, this is proposed. This is not finalized, but I'm pretty sure it's going to go the way that they're doing it. And I think that one of the reasons why we have to really make sure that we bring this forward is because that public comment is solicited and your voice matters. Just like everybody thinks, well, my voice, I don't know. Your voice matters. And we'll talk about one of the bigger things that providers are failing to realize in this regard. But uh, uh, participating and non-participating providers are getting a differential, and it's about 40 cents, but it still is a huge difference when it comes to reimbursement. And providers need to start thinking about how this is going to affect them in the long term.
Exactly. And when we think about the value of
Hmm.
participating in these initiatives, and I feel like, and for a long time, CMS has given, especially primary care, given them on a silver platter all these awesome services that not only benefit their patients, but also are reimbursable. And whether or not they have people on their staff that know about these services, or they're just
Hmm.
not getting messages from Medicare. And like we talked about previously, this is real, guys, that Medicare does send out surveys. And if you're not filling them out, you're the problem because you're the one hurting the other physicians out there who need higher reimbursement. If you don't fill out those surveys, guys, they're not going to know what you need. Okay. You might think that they should know, but that's the point of the surveys is to understand the status of what you need. I don't know. I mean, what if you get a survey, sometimes they're boring, they're not like, oh, just throw it in the trash, but these are important. I don't know if you're just not getting them or just don't take the time to fill them out.
And I think surveys, I mean, just like when we think about the census, right? Nobody really cares about the census when they're doing they do the census every 10 years. But the
Mhm.
census for our country is really to help gauge the resources that are needed for the income brackets, for the families that we need, and to also allocate for a lot of the things that we would think would be addressed in our Congress. But if you think about a lot of the most recent changes, the most dramatic changes that have occurred, it's based upon data, right? And you can't make any changes without data to support it. It's almost like coding. You can't code something and get a value from it if you're not able to quantify the reasoning behind it. So it's really important that the data, the surveys, and the analysis behind those surveys, and we'll talk about, how all that kind of translates, but in a broader perspective, but data negates necessity. Necessity negates resources. Resources negates survival. I'm just saying.
Yeah, right, exactly. And there is, when they talked about this practice expense methodology. So just so those of you who know, when they calculate the RVU, which coders and billers are taught to understand what an RVU is, right? Relative value unit, because that carries the calculation of how they're going to get paid. And remember, with commercial carriers, their rate is based on Medicare's rate. It's a percentage of that. So Medicare's rate is important regardless of what insurance is involved. They're all going to be important because Medicare kind of sets the standard and sets what that's going to look like. And so that is a piece of how the RVU is calculated is you have the
Right.
practice expense. For a physician that owns their own practice or is working in that side of healthcare and the professional side, that is a piece that's very important because you do have a practice expense when they're thinking about how much to pay you for a certain service, they do calculate the expense to provide that service in a practice. So
Mhm.
that's part of it. And so when they talk about the methodology they've used, they are talking about shifting how they did that based on non responses to survey data to now using the data they do have. So, I mean, yeah, maybe they should have done that sooner, but they've explained to us why they're doing this. We have a new administration there now, new people taking a look, this, term from the presidency, new cabinet members, people looking at this stuff. Whether or not it's going to happen or not remains to be seen, but I think it's interesting to see how it's shifting compared to how it used to be. Like, what are your thoughts on that, Maya? Like, do you think that because of the new administration, this is why it's being looked at, or why do you think it hasn't been looked at sooner?
Well, I'm gonna have some. Kimberly has her Kimberlyism. I'm gonna say my Maya niece version, right? I think um, with the amount of fraud that's going out, the most recent cases that have been introduced, because they had that one multi-million billion dollar case that was just coming out. And then you have to think about budget neutrality, right? You have to think about the way that our government spending has now been on the radar scope because now they're monitoring that, right? The government spending on Medicare and
Mhm.
all those other things. So I think that because there are so many different factors that are going into the healthcare funding as a whole, and this alternate payment model, which is really value-based care, right? And you got to think about the budget neutrality. And for those of you who are really kind of like, what in the world are they talking about? I mean, we could break this stuff down, but at the end of the day, neutrality is what? If something goes up, something must go down, right? And so we as a country and the cost of our healthcare has to be addressed by these many factors that are shaping the future of what our healthcare would look like when we retire because we're still paying into it and not reaping any benefits. So, there's a whole lot of ways that we can look at this, but at the end of the day, it's about fraud, it's about waste, it's about abuse, and it's about neutrality. And we all need to address these things and come to the forefront to say, look, what's happening here and how do we address it?
Right. I mean, fraud and abuse have been around for a very long time. It's not new. It doesn't get any better because we don't have, it requires everyone to care, about it. And so it's like those that care try so hard, but they can't get very far because there are bad actors out there still trying to, cheat the system, which we can't solve. We can't police everybody.
Right.
There are the, fraud police out there, right? But they can't get everybody. They get them when they can get them, and based
Mhm,
on the
mhm.
system, the way it's set up. So our job is really just to understand the rules. You yourself have the opportunity and the responsibility to be that person who upholds the law and upholds ethical standards in healthcare. So it starts with you, right? You as an individual. So think about how you play a role. Now,
Mhm,
and
mhm.
something else that we know has been talked about since 2020, it's gone up and down. They were spoon feeding us, right, with this telehealth flexibilities. And Maya, what now are they proposing for 2026 for telehealth and supervision?
Okay. Well, mm, I don't necessarily agree with this, but I will say that there are some flexibilities with direct supervision. So, what does direct supervision mean? Direct supervision means that the physician has to be in the suite for certain services when they occur, when they're allowed. And if you look on the Medicare physician fee schedule factor, it's like factor number 5 when you see the code on the Medicare physician fee schedule. So, what it means is that physicians can provide virtual supervision for services that require direct supervision. Um, we know that it's not done right, but the takeaway from this is how are you documenting that the physician was there virtually, right? And that's something that EMR optimization needs to be factored in. If they're going to do that, then there should be a call in for the physician to be on the screen when this EMR, when this virtual supervision takes place for a service that requires their attention. But there has to be a way to monitor that. But as of the proposed rule, not final, but I'm sure this is going to get final, they're allowing for virtual supervision for real-time audio. But again, monitoring this and making sure that it happens for services that can be risky, right, will need to be addressed. So again, this is something that's occurring.
So when I think about all of these changes, it's hard to keep up. But I think that it's our responsibility if we work in an organization that does offer these, it's our responsibility, even if our supervisors don't educate us like we feel they should, take it upon yourself to get on telehealth, um, .gov. I think it's HS telehealth hhs.gov, but it
Yeah.
is a great website to keep up to date. And then the Centers for Connected Health is probably the best place in the world to take yourself. You can see all of the rules by state, where you live, what's going on, and majority of the time what we really care about, and I will say this because I used to build this when I worked in the hospital, when I was still working for an organization, at actual hospital early in 2020, is that you have to understand the documentation. And I know that it's something you want to offer. And right now, you still can, for the most part, offer these services at least to the end of this year for now. So please work on giving us that it was telehealth. I mean, I still see documentation where they want to bill telehealth and there's no documentation that the encounter was performed via telehealth.
No.
What? And they're not giving us time. If they want to bill by time, they're not giving us the method they used for compliance to show that. We're still seeing evidence that they were in another state sometimes. They're not understanding the state rules. And actually, the Centers for Connected Health has very detailed instructions for your state, what your state rules are. And I do credentialing. I've said this before. When we perform credentialing services for our physicians, that's one of the things we have to tell the insurance company. Do you perform telehealth services? What types of services do you perform? They ask you, do you do them in person? Do you have like on site, or do you have a hybrid version? Do you do remote patient monitoring? They ask us all these questions because they want to know how you're set up. in order to approve you to be enrolled as an in-network provider. They need to know where your license is. If you are only licensed, let's say in the state of Arkansas, where I am, you're not allowed to practice medicine in Missouri or
Unless you're
Oklahoma.
licensed. Unless you're licensed
Yeah.
and you have a licensure agreement for the Connected Centers for Health Policy. Yes.
Yes. And if your
Mhm.
patient lives in Oklahoma or Missouri or Kansas, which I'm talking about our 4-state area we have around here, which we typically see patients, like we're in the northwest corner of Arkansas. So we're really close to Oklahoma and Missouri, like right there.
Same.
So
Hmm.
we often get those patients that come across the border. Maybe they live in a county that doesn't have great health care. So they jump over to our area because we have a lot of great healthcare opportunities. So we do get a lot of Medicaids and different people from those areas. So whenever they're looking at that, your patient, let's say they wanted to telehealth, but they are physically in their home state, you are now saying, if you bill that, I am licensed in that state to practice medicine. And if you're not, you are violating the law. Plain and
So
simple.
true. So true. And telehealth, it's a method of healthcare that needs improvement, but it is necessary for today's times. And I think with today's administration, and these proposed rules that are associated with it, it's really time for people to really kind of get involved with the improvement of the overall process, making sure that there's a place for those younger, the elderly to get telehealth. Because now there's a rule as of 2025 that if the elderly cannot have a service over telehealth, that they can do it over the phone. But you got to say that they're doing it over the phone and you still have to bill it telehealth. Not just because they're doing it over the phone and you could just bill it. No, I mean there's just a lot to be desired in this space. But we're in a day and age where it can't be ignored anymore to the point that it has been. There has to be a lot of granularity that has to be addressed with this.
Exactly. So, I mean, pay attention, and we're going to keep you updated, on the podcast. If you're part of our actual membership, our specialty membership for specialists in primary care, practice, specialists, and all of you guys, reach out to us if you want to participate in our membership, because, that's where you can get direct access to us to keep up to date on things so that your organization can run smoothly. You'll get those updates from your consultants that can keep you updated. Now, I do want to talk a little bit about this proposal for the Ambulatory Specialty Model, the ASM.
Hmm.
It's proposed as a mandatory payment model, and it's really going to work on specialists who deal with patients with heart failure and low back pain.
Yeah.
Now, we in orthopedics, and I work in the spine, I have a lot of clients who see patients with back pain. So I will be making them aware that this, of course, is not coming for another year potentially, but I want you to know how it may impact you. So we're going to be doing some more information coming out on that, but I think it's important to address it. You have the potential. Again, it's about risk-based model. So they want you to reduce the risk. How are you doing that? And I've seen a lot of cases, from the OIG that they have monitored. And if you go out and look at some of the things happening in the spine world, and of course, other patients with other conditions, they're very concerned about the risk to these patients because of what has happened previously to these patients. So they're going to reward you for being participating in this model, either good higher payments, right, for good performance, and potential for reduced payments based on performance, your quality, cost, care improvement, and stuff like that. So they're going to look at the data. Data doesn't lie. And we used to have to do this a lot with where we had our PQRS that we used to do back in the day. But it's really important to track these things. It's not just about, reimbursement, which they're trying to incentivize you because they want you to do better in taking care of your patients. So it's a win-win for the patient and for you if you participate. And if you're thinking, oh, the burden, it's too much work, well, then do you realize that it's not that much work when you're efficient and organized? How many practices are just so disorganized that they're overwhelmed? Yes, they don't have the right people helping them get organized. And I just don't get it because I see practices that are super functional, so on top of it, that do this really well.
Yeah.
And I just like, and how does the other ones not do it? It's because of their lack of communication skills and their lack of organization
And
in
education.
general.
And education.
Education.
And I'll just say this. One of the things that I've really have noticed is that, uh-oh, Jen, I'm getting in my soapbox. A Maya needs moment, right?
Mm-hmm.
Category 2 in the CPT book is just as important as category 1 because it's associated with meaningful use and quality care for your patients. If you do not have that set up in your EMR to report these types of problems that they're speaking of in this model, you're going to have some big problems because you have to make sure that you're reporting the services appropriately, and that if you want to get credit for these types of programs, you've got to start using this physician quality metrics model that's in category 2 that helps you identify the services that you're providing to your patients in addition to the codes that you're being reimbursed for. That's a huge deal. And if you're not aware of that, you need to talk to Healthcare Inspired, you need to talk to someone who would be able to help you assist that to help optimize and report those services that you're already doing for you to get the credit that you deserve for the quality measures that you're taking for your patients.
Exactly, exactly. So it's about quality, it's about understanding what you're getting paid for, what you're not getting paid for, and they will reward you for doing a good job, right? Like I love getting rewarded for doing a good job. We're always told to give our staff like a good incentive for doing better. Why wouldn't you? You
Mhm.
know, it's a good way to promote quality care and just in general good business practice. So again, I do
I
think
mean,
it's
it's
important
called
to
MIPS.
do that. Yeah.
It's called MIPS, Metric Improvement Performance Systems, right? MIPS, that's
Yes.
what MIPS is about. So, I mean, if you're not, okay. I digress.
It's all right.
Le-
It's all right, Maya. We feel you. We feel it. We're all feeling it, girl. Well, and then finally, we only have so much time to dig through this, and we'll give you a lot more down the road, but we just wanted to talk about some of the key areas. And one of the things I was kind of interested in because of working in plastics, working in podiatry, is these skin substitutes. So in 2026, they are proposing to unpackage the skin substitutes products from their associated, obviously, application services where in some of these, so this is the ASC and the ops changes. So just to clarify, this is for the ASC. And you understand AC billing, there are some things that are kind of a package deal where you submit a code and it includes certain things and the cost of everything is included in that bundled payment that you get, right? So they're considering unbundling some of that and packaging it. Now, part of it has to do with obviously the huge amount of money and fraud that is just out there with skin substitutes. It's insane how much they're paying out that was inaccurate. And so they've
yeah,
caught it. But they want to incentivize you. And I love like they're all about this competition, right? There's a lot of great products out there
yeah,
and they want to incentivize the ones that have great products to now potentially capture that. But also, it's going to hopefully reduce the cost to Medicare because they're going to be able to calculate and really see how much is being spent and utilized accurately,
yeah.
efficiently. So this would really require auditors like us, those that work in that field regularly. I've been in podiatry for a long time. I am a podiatry consultant. I work with a lot of podiatrists. That's very big in the wound care area. I also work in plastics and other ENT has a plastics area. So we talk about that with ENT. anywhere you're having to apply skin substitutes. I used to work in general surgery for a burn physician. So my entire career, I have spent in various aspects of using these skin substitute codes. And I will tell you that a lot of times I would see so many red flags over the years of this being done incorrectly. And providers not understanding the purpose of these codes and how to use them appropriately with the wound prep codes versus adding the skin substitutes, understanding the different types of skin substitutes and which codes apply to those different types. And so it's really just understanding. And when we teach coders, even, that's one of our jobs to teach future coders. You got to understand what each code was designed for to report it correctly. And that requires an understanding of why the AMA created the code, what the description actually is trying to tell you, and then looking at the payer and saying the payer allows this code, but with some stipulations. And I still see people that don't know how to interpret a CPT code. And it's clear as day in the guidelines, in the description, what the code's for. And they've revised it a lot over the years to make it more clear. But even to me, I'm like, I read this 10 years ago and it was very clear what this code is for. And they still don't get it. They still don't get it, Maya.
Yeah, it's okay. Again, I'm bursting at the seams because there's so many things. Coding and reimbursement is not just understanding what to bill. It's also about what to report, right? Categories 1, 2, and 3 in the CPT book is about category 3 is for new and emerging technology, category 2 is for quality measures, and category 1 is for reimbursement mostly, right? But again, when we think about all of this as a whole, right, you have to understand for your business, you got to know all parts of the CPT book, right? There's reasons why you report them. There's reasons why your organization or your specialty representatives to the AMA and have the editorial panel describe these things so that they could be reported to add value to it. That's why they have a RUC committee, right? Resource utilization committee, right? All of these things are really part of the cogs of the wheel for reimbursement. And so I think it's important when we think about the skin substitute reform and the proposed rule and the average sales price for these services, right, that they be reported appropriately for new and emerging technology so that they can accurately make the adjustment for the services that are being performed and how reimbursement should be addressed when it comes to those types of things. I'm just
Exactly.
saying.
And so, yeah, you're right, 100% right. So I think what we've covered today is just really important stuff to keep on top of. A lot of people don't even know that there's a proposed rule that hits in July. You have until September 12th, guys, to decide what you like and don't like. Otherwise, it's moving on without you, like every year.
Yeah.
so
Oh,
so don't complain in January if you didn't participate. Don't complain.
yeah.
I don't want to hear it. Don't want to hear it. Cry
And
me a
they
river.
usually,
You didn't
I was gonna,
participate.
don't do that. Don't do that. Don't start. Don't start. But I will say this, right? The proposed rule is a proposal for public comment until September 12th, right? It's usually finalized before the AMA symposium, which is November. You have some time to voice. Just like, and I'll just say this, Jen, and I promise, I won't go off keel. But I will say this. The CMS AMA has been looking for public comment on specific surveys since 2006. They have only received 3 to 6% of responses based upon seeking public comment since 2006. Think about the car you were driving in 2006 and the car that you're driving now. Think about how technology has advanced in the car that you're driving from 2006 to now. And think about how much it costs to fix it and to fill it up with gas. All I
Absolutely.
gotta, that's just all I gotta say. In the words of Forrest.
Yes. And there are a lot of specialty societies, like Astro is really, really a great society for the radiation oncology. And then we have the the Otolaryngology Association, ENT.org. We have AAOS Orthopedics, the is it the American Family
AAFP,
Practice Association? Yeah, it's it. You
AAFP,
know, they're so involved, and
American
so if you're
Colleges of
in a special,
Physicians.
yes, ACO or ACP, yeah, my acronyms. I just, it's one of those.
Girl,
It's
listen.
Monday. I can't remember all of them, but again, think about what your specialty is. Go to your specialty society. They will also give you information because they are very involved as well. So maybe it's just like a handful of each specialty that's getting involved, but that doesn't mean that more couldn't. They give it to you on a silver platter. They always give you information. Your physicians most likely already are members of that. So if you're an administrator, make sure that your physicians are giving you information and handing that down to you, or become a member yourself. Just get involved in those societies, really important, because that's going to be where they post most of their updates and what they're working on, right? And go to the
Yeah.
AMA symposium if you can. It's virtual. Maya and I are going to attend this year. It's a great event to really know what's happening at the AMA and CPT and what's coming. So we encourage you to review the rule. We will post the official link to the Federal Register in our show notes, so you have access to that. It's also all over the internet if you Google it, so not hard to find. And attend your association's webinars, attend other webinars that are out there. They're going to give you more information. Some of them are free, some of them cost, but isn't it worth your time and money to make more money in the future? To invest in the future of your organization? I think so. So thank you guys for tuning in to this special bonus episode. We'll be back again next week for another episode. This week we're off on our normal Wednesday episode, but the following week we'll be back for another episode. So stay tuned for that. Have a great week. Have a great rest of your week and a great rest of your summer. I know kids are starting school soon, so parents, here you go. Have fun. Send your kids off to school again. Enjoy the rest of the summer. Thank you, Maya. Thank you, everyone, for listening. Have a great rest of your day. Thank you for always